Welcome to the TechLink Health Podcast, an on-demand source for the top trending healthcare topics and insights. Delivered by key opinion and emerging leaders and as featured on the TechLink Health app. The healthcare industry is rapidly evolving, so our goal is to connect listeners to the most relevant insights, ranging from digital health to financial well-being to interesting side gigs. For more details, visit www.techlink.health.
Well, hello, everyone, and welcome back to the TechLink Health Podcast. I am Justine Reese, and today's episode gives listeners unique insights into the future of health with a particular focus on health literacy. I'm excited to tell you this episode's guest is Dr. Ogan Gurel, a Chief Science Officer, founder of the Mini Medical School, Mini MD, and author of Waves, the book, which is a story that recounts the adventures of the contemplative and idealistic Tomas, a doctor turned entrepreneur who's discovered a new technology with both medical and military applications. His experiences span the executive marketing, clinical, and R&D domains, with sector expertise in medical devices, digital health, medical imaging, and biopharma, as well as academic research focused on protein, electrodynamics, and terahertz medicine. Just a couple little things. He also serves as a venture partner and chief marketing officer, in addition to several academic appointments. Dr. Gurel holds an MD and MPhil in Biochemistry and Molecular Biophysics from Columbia University, as well as a Bachelor of Arts in Biochemical Sciences from Harvard, where he conducted research in molecular dynamics with Martin Karplus, who was awarded the 2013 Nobel Prize in Chemistry. Wow. Well, it goes without saying that Dr. Gurel has a truly unique perspective into the world of health, and we look forward to getting his perspectives. So, without further delay, we are very excited to welcome you, Dr. Gurel, to the podcast, and thank you so much for joining us today.
Thanks, Justine, for the kind introduction and the opportunity to be on the podcast. I also thank TechLink Health. It's a wonderful opportunity, and look forward to our discussion. You can call me Ogan, by the way.
Yes, thank you. I was going to ask you, so thank you. I will call you Ogan. So it would be great if you can give our listeners a little background, introduce yourself in your own words in a little more detail about your journey into digital health and medical education.
Well, you touched upon a lot of the major points. I'm originally a doctor by training. I got my medical degree at Columbia, but you also noted some of the scientific aspects. So I also have a fairly intensive scientific background, but I'm not a full-time practicing scientist. So that's the medicine and the scientific. And then I've also been in the business, the investment and consulting worlds, as you noted, around the globe. So I have those sides. And so it's a little bit multidimensional. And one of the ideas has been very interesting. You mentioned about protein electrodynamics and terahertz medicine. It's one of my research interests that actually started with Martin Karplus when I was an undergraduate. And as you know, he was one of the founders of molecular dynamics. The basic idea is that proteins have electromagnetic implications, if you will, just to keep it simple for now. And that has a lot of implications for medical and military applications, as you mentioned. And of course, if you have a really paradigm shifting technology idea, just doing the science alone, which is very important, of course, is not the only thing. There's a whole dimension of the business side, the financing side, the ethical side, the moral dimensions. So my career has been to try to develop many of these dimensions, if you will, but centered around this core idea and healthcare innovation more generally.
Right. So you're multi-dimensional, which seems to be a theme. So the Mini Medical School program, it's very innovative in health literacy. Love to hear a little more about the program, its benefits, and particularly as it relates to TechLink Health users, which are a shared demographic of consumers and healthcare practitioners. Also, on the topic of health literacy, what does the future hold in terms of medical education, particularly as it relates to the use of some of these new technologies for both consumers and professionals?
Yeah, so as I mentioned, from a scientific basis, I've been interested in this rather technical area that I mentioned, protein electrodynamics and terahertz medicine. But that's embedded more in a broader interest in healthcare innovation and innovation more broadly. You mentioned in your introduction some academic appointments, so I've taught innovation and etc. But the reason I say that is that I spent a decade in South Korea. I was brought by Samsung Electronics back in 2010 as they were going into the healthcare space to help with their innovation. And I joined the Central Corporate Research Lab. And of course, they're not a healthcare company. And Samsung has some very smart people, top people, students in Korea. Many of them go to Samsung. So they're really smart, really educated semiconductor engineers, mobile executives. But to be very frank, they just knew very little about healthcare.
Right. And I'm curious, like I think of Samsung and I think of
Well, right,
communication.
right. So they wanted to go into healthcare. And this is a long story. I don't want to spend too much on the podcast. It's about their strategy, their chairman, their second chairman. His name is Lee Gun-hee, and his vision and all that. And obviously there are other tech companies, Google, Apple, et cetera, that go in and out of healthcare and et cetera. So this was their effort. And they continue to be involved in healthcare to some extent. But the point is, I was one of the relatively senior people in that Central Corporate Research Lab, that innovation hub, if you will. And I said, well, why don't we do a mini MD course? There are mini MBAs out there. I'm sure many of your listeners and viewers have heard about mini MBA. And I said, well, I can package a mini MD course for them, which I did. And then I was there for 4.5 years. And then after I left Samsung, have been teaching the mini MD for the past decade all around the world, mostly in Asia, because I was based in Asia then. And then since the pandemic, I've been doing it virtually. And to really bring this health knowledge to the professional healthcare community. Now, the reason why this is important is not just because you have to have more knowledge, et cetera, but one of the key problems in technology and healthcare is how to make that leap. Some people call that translational medicine. And part of that leap is understanding how doctors think, how to communicate with clinicians, understanding the problems in medicine, and most importantly, how medical issues are integrated. And it's not just compartmentalized. I'll give you a quick example. A cough, differential diagnosis of a cough. Most people think of lungs, but it could be your heart. It could be your upper respiratory tract. It could be your stomach, gastroesophageal reflux. So doctors are trained to look at the whole body, and technologists have to do that. And I don't want to go into a lot of details, but one of the major reasons why healthcare startups fail is that lack of ability to understand how the technology is embedded into the wider healthcare system, that lack of ability to engage with doctors and get them to adopt the technology. And so teaching this course really brings that broader vision and knowledge to the community.
That's fascinating. And that's a lot. And of course, my brain goes to how we all started using more technology during the pandemic. Did you find in this last year and a half, almost 2 years now, some new avenues into adopting more technical ways of using healthcare?
Well, yes, of course. That clearly goes without saying. But what's interesting is I was in South Korea at that time. And South Korea is very advanced in terms of tech. Samsung's mobile smartphone penetration is like some ridiculous 99% of people have smartphones, and internet bandwidth is the fastest, internet speeds are the fastest, and so forth, jostling with Singapore for number one. But what's interesting, a lot of people don't realize, is that telemedicine, which is not the only part of digital healthcare, but a significant portion, is actually not legal in South Korea. Now, I don't want to spend a lot of time. I've actually talked on other podcasts about this, but the two major reasons why it's not legal is, well, it's a little bit complicated, but the way that it works is that they have the academic medical centers, and then they have the general doctors as well as specialty clinics spread out. Their healthcare system is very decentralized, which I think is very smart. You can go around the corner and you go to your internal medicine doctor. And high quality, I was living there, I was also a patient, like all of us, right? So I was experiencing it. And the problem with telemedicine, as the South Korean government thought, is that if people all go to the academic medical centers, then their beautifully distributed, efficient, effective system gets undermined. If you just call up, you can go to the top hospital, right? And then, of course, the flip side of that, which is related, and I don't want to make it sound like the doctors are motivated by money, but those decentralized doctors would then lose their income. And so they were not happy with it. It's complicated. And then the third reason why telemedicine is not legal is that actually there's not a big market case. It's a small country. As I said, there's literally a doctor on every block. So in geographically dispersed populations, Texas, Australia, whatever, many places around the world, telemedicine can be life-saving. In Korea, in a way, it's not that necessary. But the reason I mention this is that during the pandemic, as the pandemic broke, the government made exceptions. They said it's not legal, but we're going to allow chat consultations for prescription renewals, things like that, simple things. And they allowed that and essentially made an exemption. So it hasn't gone full-blown telemedicine for the reasons I described, but it was an interesting case study of how technology changed.
And it was interesting here, too, because some doctors wouldn't treat you if you were even out of the state for a separate period of time. I mean, it's just gotten so complicated. In Korea, is it free?
I'm now in Montreal, Canada, which is a very interesting system. It's a free system. Korean system is a little bit of a mix. And in the mini MD, I have a section about healthcare systems and a couple of slides comparing systems, comparative healthcare systems. So I talk about this. And it's so funny when I sometimes give presentations and I have a slide about how all the different healthcare systems, how do you have that slide prepared? Well, it's part of the mini MD. So I just show that. But anyway, Korean system is not socialized medicine, but it's not a free-for-all either. It's a public insurance with private provision of the healthcare. So it's a mixed model. But the public provision is not like the Canadian system or the National Health Service in the UK, where it's completely free. It's actually 80-20. I mean, I'm simplifying, it depends. In other words, the government or the National Health Insurance pays 80%, and the patient pays 20%. And I think it's quite reasonable. I remember when we first arrived and I had a contact lens stuck behind my eye, and usually it's not a big deal, but sometimes it's like doesn't come out. So I went to an ophthalmology clinic, one of those clinics that are in the neighborhood, right? Obviously, there's not an ophthalmologist on every corner, but they're around. So I didn't have to go to the emergency room. I just went to the clinic, right? And in America, or in many places, you have to get the primary care doctor, gatekeeper to approve it, or you go to the emergency room and all that. So I just go to one of these clinics. So you can see why this system is very efficient. No one has to go to the emergency room. You don't have to muck up the primary care process. So I went there, and in about 30 minutes, they saw me and checking with a microscope, everything. So it was a little bit too much for just a contact lens, but I'm okay. It's better than doing the wrong thing. So they were very professional and fixed it and everything. And my wife and I are there, and we get the bill, and it's $4.
I was just going to say, what happened? I'm
$4.
expecting that comment now.
And we
$4.
Yeah, $4. That's the copay. So
Wow.
I guess the total bill was like $40, or maybe more. I don't know. So we looked at each other and said, "Oh my God, looks like they made a mistake. We got to get out of here." I was joking.
Quick.
Quick, before they realized their mistake.
Right.
But it wasn't a mistake, of course. And there are two interesting aspects to this. Number one is, well, three interesting aspects. One is you don't need to go through this referral process for a lot of basic specialty problems. An eye problem is just has to go to an ophthalmologist, okay? In general, they're not going to penalize you like if you had an insurer. You said, well, you didn't go to the primary care doctor first, or you need to get it first. So waste time. So that's number one. Number two is these specialty clinics were not in some hard to get to hospital. They were all out in the community. So that was also very easy. And the third thing, of course, it was reasonable cost. And I don't think it has to be completely free. I mean, obviously, if people are very poor, they do have subsidies for very poor people, so that it's free. But in general, I don't think it has to be completely free.
There's a happy medium, but I feel like when January hits, people freak out because their deductibles are starting over again, and then they're reticent to even go to the doctor.
Yeah, it's so distorted. It's very strange. I mean, to make decisions in your healthcare because you have a deductible here, and then to pile up all the healthcare at the end before it runs out, and all this, it's weird. Which is ironic because people say about free market healthcare, but there are more distortions in the free market healthcare than in the Korean healthcare systems, where you just go to the doctor because you have to go to the doctor. And you go to the right doctor.
It's like they're onto something.
Yeah. I mean, I have lectures about the Korean healthcare system. So if some of your viewers want to reach out to me about that, who are in healthcare services or policy, not to say it's perfect, but I think, like you said it nicely, they're onto something.
Yes. Well, I think in terms of policy in particular, because if those are things that we can start looking at and changing, and why not? We are in an era of change in every way. Okay, well, let's talk a little bit about your book. You know, many of our prospective listeners are healthcare practitioners, innovators, and entrepreneurs. So I want to talk about your book, Waves, and the insights that can be derived from it with regards to the entrepreneurial journey. Now, I know that it's fiction, but this is fascinating to me when we take real life and somehow fictionalize it to make it more relatable.
That's right. So let me frame this. First of all, it's a fun book and people can find it on Amazon. There are lots of reviews so they can read what other people say, not just me or you, Justine, no offense. But the point is it's a fun book, and fiction and all that is supposed to be interesting and stimulating and fun and all that. But there's a backstory to this, if you will. I told you I had worked in the protein electrodynamics in this technology, and you alluded to it in the introduction, the medical and the military applications and so forth. Well, that's the kind of technology background, and this is great for your audience, the TechLink Health. It's the background to this book. And the book is called Waves. So it's about electromagnetic phenomena in biology, but specifically about proteins, which are the machinery of life, the target of drugs. And these proteins have functions, whether it be, our brain cells, muscle cells, everything. And those functions are in large part driven by these vibrations of these proteins, what we call molecular dynamics or protein dynamics. I know that sounds a little technical, but imagine them like little nano machines. They're not just billiard balls bouncing around. They have their own personality and their own activity. Let's call it vibration to make it simple. Now, this is a little bit technical, but I think it's straightforward. If you know a little bit of electromagnetism, basic physics, electromagnetism, in other words, radio waves and all these waves arise from charges, positive and negative, that are vibrating. That's what's happening in a smartphone. That's what's happening in a radio, etc. And if the protein has charges, and they all do, and they're vibrating, guess what? They will be like radio, emitting and absorbing this radiation. That's called protein electrodynamics. And then the medical applications of that, as well as military applications. Well, the medical applications I call terahertz medicine. So about 12 years ago, I realized, and as I said in my introduction, technology is not just an isolated thing. It's embedded in society. So that's part of the reason for my multidimensional career, as I mentioned, as you mentioned. But technology has all these sides to it. And I said, well, you can't explore all the sides with a business white paper necessarily or a scientific paper. The best way to explore the complexity of life is with literature or art in general. And so I wrote a novel, and that novel is called Waves. And it's about this technology, but it's not science fiction really. It is what I think would be best described as a 21st century version of the Faust legend. And that gets to your point about the entrepreneurial journey. Is Thomas, the protagonist, in order to bring this idea to fruition, the medical side, makes a deal with a hedge fund manager, modern day devil, although it's more complex
I
than
was
that.
going to say, for those that don't know, that in Faust made a deal with the devil.
Yes, that's right. And Goethe's famous work, and so it's the Faustian bargain.
So Thomas makes a deal with
Max. Yeah, Max is a German-American hedge fund manager. Very intense guy, incredible personality. And he turns out to have a softer side. I don't want to give too much away because he's not the pure devil. And Thomas himself, he's a doctor, but he has some sides as well, that tries to explore the whole complexity of things. And I can read a short passage, if that's okay with you.
Yeah, that'd be great.
So this is actually not just a passage, it's a sentence. It's the very first sentence of chapter 1, the very beginning. And Thomas is driving up the mountain in the south of France. So it's a beautiful scene in the Côte d'Azur, above, near Monaco and all that. He's driving to the mansion of this hedge fund manager. He's contemplating how he's going to make the deal, etc. And he's driving up. So this is the first sentence. Squeezed between aspiration and despair, Thomas downshifted, pleading for the underpowered rental to cough up more torque. Now, that may not sound very significant, but that sentence, and this is the beauty of fiction, you can compress a lot of meaning. That sentence describes the essence of technology. Technology has two sides to it. It can be for good or for evil, to put it simplistically. And in this case, it could be medical or military applications. Now, what does downshifting have to do with that? So for anyone who's driven a manual car, downshifting, you can do two things. You can accelerate or you can decelerate with the same gearbox, which is the metaphor for technology. The same gearbox, the same motion can do the opposite effect. And the opposite effect comes from your intention. And that's the human side. So that's encapsulated in this first sentence. Squeezed between aspiration and despair. So there's an emotional also dichotomy kind of there. Thomas downshifted, used the technology, pleading for the underpowered rental to cough up more torque. But the torque, we don't know. Is it to accelerate off the cliff? Is it to decelerate to make the turn? Is it to accelerate to go faster, to meet max? Torque, again, is a technical concept. And I'll just continue one more. Like the little engine that could, the car groaned to scale the craggy ridges overlooking the Côte d'Azur. Snaking along the Grand Corniche, perched between dream and reality, the Ford buzzed, clinging astride steep slopes etched by a winding blacktop that had once hosted growling Ferraris and McLarens revving for the Grand Prix. So you see the contrast between the Ford and the McLaren. So there's these contrasts going on. And that's what this book is about, because as Thomas is in his entrepreneurial journey, making his bargain, there are geopolitical forces developing the military weapons, and they're doing their bargains behind the scenes. So there's other plots that emerge.
It's really interesting. So I am curious about how you, with this scientific background, which sounds very technical, became this very great writer with such great detail and amazing metaphors to tie all these things together. How did that happen?
That's a good story. And it goes back to earlier in my life as these things go. And I had a very interesting education. You're from New York. We were talking before in our mutual introductions. And I went to Stuyvesant High School, which is a top high school, as you know. Science, a lot of Nobel Prize winners come out of that. But I also went to another very good high school. Listeners may not know it as well, called Hunter College High School. Hunter College High School, I went there for 7th and 8th grades, but actually it's a really top school and many people just stay there. But I made a very unusual decision to transfer from Hunter College High School, which is in some ways even more exclusive than Stuyvesant. These are both public schools, by the way. So when I mean exclusive in terms of getting in, and I made a decision to go from Hunter to Stuyvesant. Now, Hunter was a very interesting experience for me. I was the second class that was co-ed, and it was originally a girls' high school. This is in the late or middle 1970s, so I hope I'm not dating myself. But this was a girls' high school, and I don't want your listeners to get me wrong, but the times then were quite different. There were different expectations of girls and women. So Hunter College High School, which is one of the top high schools in New York and in the nation, because it had this test and everything, was a girls' school, and I was a second class. So I remember we were in gym class and we were doing, calisthenics to help us strengthen our backs for pregnancy. And
You mean they didn't quite
change the
update
curriculum. They didn't
the
update
PE curriculum
exactly right.
for the
So
co-ed.
they eventually did, but it takes some time, and I was a part of the guinea pigs, whatever.
Yeah.
So I remember these exercises with my face on the floor, arching my back. I've never done this before and never done it since. And they explained it's for pregnancy. I said, oh, great. Okay.
Hilarious.
If I get pregnant, I'll be all set.
And by the way, I question that they were preparing the girls in high school for pregnancy, but that's a whole other.
Well, no. I mean,
thing.
It was actually smart. This actually raised the health literacy, which we can, talk about afterwards, because I had health education and you really want to prepare. I mean, they're not going to get pregnant right away, of course, but back exercises and general fitness should start early. So the other thing that was interesting, so I was really a big fanatic for soccer. There was no soccer team because it was a girls' school and at that time. So Stuyvesant had a soccer team, not very good, but I wanted to do soccer. So that was one reason. But the other reason was Hunter wasn't that strong. It was pretty strong, but it was not really focused on science because women are not expected to do science. And again, nobody should be offended. This is not me saying that. This is just, that's the way it was back in the 70s. And I'm not saying the science was bad, but it just was kind of like less emphasized. But humanities was incredible at Hunter. And, I was reading books and they really pushed us and it was very sophisticated. And I got this humanities bug. Those 2 years I was at an all-girls school. And I'm so grateful for that because those two experiences made me have different perspectives.
Interesting. So that's how that came about. Okay, let's talk about the future. And in more recent trends, the metaverse has been an emerging topic of interest. So tell us about the relationship with what you term in your book terahertz medicine. I think you've already talked about this a little bit, but let's expand. How does this emerging innovation impact your work? And how do you see this playing out in the future? And how are we all going to benefit?
Sure. Well, the metaverse is a kind of evolving concept, and like many, there's buzzword aspects to it. I think it's a little bit less relevant to the terahertz medicine, which is a more technological device. But the metaverse has interesting applications for the actual book. So you mentioned about screenplay and it's a cinematic and so forth, and I appreciate that. And I did write so that it kind of comes out that way, visually, et cetera, obviously, in addition to the sounds. But the other thing, I wrote the book almost like a new type of book. Now, what do I mean to say? As you can tell, music is a very important part of the book. And in many movies and books, music is sometimes decorative, or we call it background music. Music in this book, in Waves, is integral to the book. It is the central metaphor. Imagine the proteins with their electromagnetic waves emanating and communicating. And I'm obviously simplifying, but just imagine that for a moment. It's like a symphony orchestra. And so this is the music of life. And so music is very appropriate part of the book. How does that relate to the metaverse? So I designed it, I wrote the book so that as you're reading, I imagined that there was this technology. Something is tracking your eyes, or it's at least seeing where you are while you're reading. And the music starts to play while you're reading, linked to where you are. So I call it kind of like operatic literature or literary opera, whatever. I don't know the exact name for it. So that's not the full metaverse, but I think you can see that's some element of that. And I would like to develop, if there are people out there in your audience that are developing some of these technologies, where I think Waves can be kind of a really good test case of this concept, which would be one incarnation of this metaverse idea of melding together different senses and different experiences as opposed to the separate things.
Well, I have to say, in terms of the sense, and certainly music can take you back to a time, a place like no other thing. And they say kids that play music learn a lot about math, rhythms. My father is a doctor and a piano player, and I was always really aware of that. He'll be happy I mentioned that. He's one of our biggest fans on the TechLink Health
Awesome.
podcast, by the way.
What did you say his specialty was? I was looking.
He was a radiologist.
Oh, wow. Great.
So you talk about waves.
That's right.
And music.
So terahertz radiation doesn't penetrate through the body like X-rays, but it's a kind of new potential form of imaging.
It's fascinating. That's a whole other thing. I mean, we could talk and talk. We could do a whole series of things. We talked a little bit about the raising cost of healthcare and accessibility on a global scale. If there's anything you want to add about that, I would love for our listeners to hear that. Regarding the treatment cost, what role does the education of medicine play, and where are we going with this, and how can we make it better?
Sure. Well, there were a couple threads to our discussion. One was the healthcare innovation. The other one was the protein electrodynamics and the terahertz medicine and the book around that and Faust. And then another thread, which you said at the beginning, and we didn't develop a lot, is around health education. You used the term health literacy. And I also was mentioning about Hunter College High School and PE. And I think health education is really, really important. And I'll give a couple examples. Hippocrates, who was the founder of Western medicine, has a quote. I'm not going to waste time pulling it up, but a quote to the effect that between medicine and wisdom, there's no gap. Learning medicine is learning wisdom. And so medicine is a science and the art, and you bring those together. So I think it's a very powerful way to look at the world. And like I often say as a joke, everybody should go through Marine boot camp or surgical internship.
Really?
Well,
How so?
Well, it's like training for life, I'm joking, as I said, but I think you get my point. I mean, I think knowing about your body, knowing about health is important for you and your family. And I'll make it very real to your listeners. A lot of the troubles we are experiencing with COVID can be attributed to lack of health education on the part of policymakers, on the part of many people. And some of it is active lack of information. Some of it is passive to the extent of susceptibility to misinformation and so forth. So this is not a luxury item. Let's learn about how the heart works. This is absolutely central to people's lives. It's central to social and public health. So it's very important. And I mentioned about the mini MD that I was teaching at Samsung. And this is designed, by the way, the next course is coming up at the end of January. Search for mini-md.com.
Who is that coursework geared to?
This is for healthcare professionals who are not otherwise trained medically, although I have already one doctor signed up for the upcoming course, so some doctors have taken it. So it's a pretty good level, and it's not simplistic or anything. I believe in a quote from Albert Einstein: make things as simple as possible, but not any simpler. So it's not simplistic, but it's obviously essentialized. So the main audience is healthcare professionals, healthcare lawyers, biomedical scientists, marketing executives, biopharma, med tech, healthcare architects, healthcare consultants, insurance, healthcare insurance, the whole spectrum. Now, to your point about, access of healthcare and all this, we've had all this digital healthcare out there. Big deal, right? We were talking about that. And you have a lot of, and I don't want to diminish it, but a lot of buzzwords like consumer or, consumer driven healthcare, patient centric healthcare, personalized medicine, decentralized healthcare, home care, whatever, all these great words. But make a thought experiment like Albert Einstein did. Think about it for a moment. If people don't have basic health knowledge, like a framework, I'm not talking about the ability to Google something, which is fine, but if they don't have a framework of medicine, all of those nice sounding words will have marginal benefit. Without basic health education, a lot of these great technologies will become like bells and whistles. It's the elephant in the room that we're missing. So I'd like to extend the mini MD over time to a more fundamental sort of basic health education for general public, and maybe the metaverse can be involved in that. And then I'll tell you another little secret. I would like this mini MD, which is now for health professionals, as I mentioned, to be in medical school. Now you might say, oh, that's weird. Well, medical schools are for teaching doctors. In medical school, the medical students never get a holistic, integrated, concentrated overview of the whole field, ever. So I'd like to frame this, and maybe again, the metaverse can be involved, as a 20-hour overview of all medicine. And patients complain, I'm bouncing around from specialist to specialist, the fragmentation of healthcare. Guess what? That originates in the nature of the education process. And I'm not saying that specialization is bad. It's very good, very important. You want the person doing your bypass surgery to be a specialist in that, that's fine. But the actual MD, the training, is in general training. And then you specialize. So good doctors are always looking at the big picture, but the way it's kind of taught and the way it works in the system is they can't really do that. So I think that having this experience in medical school of a holistic, integrated sort of boot camp of everything together, I think can make a difference for that as well.
Well, I have to tell you, I love the direction you're going. I don't want to say use the word simplify because it's actually quite complex, but you are making very heady concepts accessible to someone like me, who, yes, I'm the daughter of a physician, but I certainly needed him as an advocate in all of my journeys.
Yeah, well, if we can empower a patient, we talk about empowering the patient. How do you do that? Well, it's not just giving you a smartphone app or the ability to type in a Google or whatever. It's some fundamental knowledge. I'll give you two examples, one from art and one from COVID. From art, one of my inspirations is a famous painting in the MoMA, Museum of Modern Art, called The Red Studio, L'Atelier Rouge, The Red Studio. And it's a painting of his studio. And what's interesting about that painting is it's not his studio in microscopic detail, it's highlights of his studio. He's selecting certain images that he thinks are significant to express the essence of his studio to the viewer of the painting. So he's trying to express things. You could study this for a long time. It's simplified, but it's the essentials of his studio, not by atomic detail. And in fact, he has a famous quote in French, l'exactitude n'est pas la vérité, which means exactness is not the truth. Now, I'll tell you another example. That's the art side. What I think about simplification is in the early days of COVID, I was doing a lot of podcasts. I was on news channels in Korea, leading news programs, talking about COVID. I'm not an Anthony Fauci. I'm not an expert virologist, but I have a good, solid general knowledge. And I made predictions in the beginning that there would be a lot of variant. Now you might say, wow, how did he know that? It's spooky, right? Well, it's actually very simple. There are two types of genetic material in viruses, DNA viruses and RNA viruses. RNA is intrinsically, based on the biochemistry, intrinsically more prone to mutation than DNA. So that's why the flu virus is an RNA virus. And that's why the flu vaccine changes every year, because it mutates. And so coronaviruses being RNA viruses, I could guess, but it's a very informed guess, that it's going to mutate. And guess what? I was right. But I was right because I was basing it on a very simple, you see? I wouldn't.
Okay, so now I want to ask
Yeah,
you,
what's my
now that
prediction?
yes, you were right. Yeah,
Okay, I do have
I
another
do.
prediction. And I
Okay, I
actually
want to
said
hear
this
it.
early on. If you look at a graph of transmissibility versus mortality, transmissibility refers to the infectiousness and mortality refers to the pathogenicity or how severe it is. So the actual numbers associated with that would be the R naught. You probably heard that. The R0 as a measure of transmissibility, and the number of that's related to mortality would be the case fatality rate, for example. You can have a number of numbers. So imagine the horizontal axis as transmissibility. So to the right is more transmissible, closer to the zero is less transmissible. And then on the vertical axis, you have mortality. Higher up is more fatal, lower down is less fatal. And if you plot all different pathogens from Ebola to measles to flu, etc., on this, you'll see a kind of inverse relationship. In other words, more fatal, like 50% fatality rate, like Ebola, is generally less
Right.
transmissible. And more transmissible is less fatal. So you have an inverse relationship. That's number one. And the other piece of information, this comes from like basic science, is that in terms of evolution, these pathogens tend to go towards less fatal, more transmissible, because that makes evolutionary sense. Because if you're killing the hosts, you don't have anybody left. I mean, that's a little bit extreme and I'm simplifying. But the point is, by being transmissible, you do your job. And it's fascinating because another concept that I mentioned in the early days of the pandemic is also from the mini-MD, is the difference between an upper respiratory tract infection and a lower respiratory tract infection. So upper is kind of all the sniffles and everything. It kind of doesn't kill you, but it's very transmissible. The lower is when you have respirator, pneumonia, blah, blah, blah. So you know the deal. So what's interesting is COVID was both, right? So that was a problem. Now, if we look at Omicron, they're saying, you read the literature and it says, looks like it's more in the upper respiratory tract. So if you have this mini MD kind of framework, upper respiratory, lower respiratory, blah, 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 it's very easy to get a handle on these things. It doesn't mean you predict everything, of course, but it just makes sense. So this will pass. It will go. And then the mechanism of that is kind of what I explained about transmissibility and mortality and so forth. But I should mention that should not let people say, oh, Dr. Gurel says it's going to go away. And here's another prediction I made. I predicted that there would be a vaccine. Now, you might say that's obvious, but as you know, HIV, we do not have a vaccine. Why? Because HIV infects the immune system, shuts it down. So it's very hard to make a vaccine against something that's shutting the immune system down. But even though COVID, SARS-CoV-2 does have immune effects, it doesn't really kill the immune system like HIV does. So my prediction was not to say it would be easy, but in the early days, I said, we will get a vaccine.
Have you managed to not get it?
I have not gotten COVID.
Neither have I. So good for us. Well, this has been amazing.
No, thank you, Justine.
Yeah, so good. Any final recommendations for those interested in staying connected to the next wave of innovations within digital health and medical education? Also, if somebody wanted to take your course, what would they do?
Yeah, so first of all, I'm on LinkedIn, so people can connect with me on LinkedIn. I encourage whoever that sets up a conversation or a connection, I'm happy to do that. The book, Waves, which if you have New Year's resolution that you want to read something different and really push the boundaries, I think Waves is the book for you. So just Google my name, Ogan Gurel, and Waves, and you'll find it on Amazon. And then the third thing is the mini MD, which I offer. It's kind of a side project, although I'm very passionate about it. So it's not exactly predictable when I offer it, but I'll be offering it at the end of January. It's a 24-hour, 8-session, 3 hours a session, overview of all of medicine, from anatomy all the way to radiology, psychiatry, endocrinology, neurobiology, all that. And you can also Google me, Ogan Gurel mini-MD, or just go to mini-md.com. And there'll be the registration information and all that there.
So head over there to grab a seat, potentially for that. Well, I have to say, thank you for making this session absolutely fascinating, entertaining, fun. You're great to talk to, and taking complex ideas and actually making me more interested in finding out more about them. There's a wave there. There's a tidal wave.
Should I end with one last piece from Waves, if you have
Sure.
time? So this is from the beginning, and it's from the opening prologue. It starts out, so at the very beginning, before chapter 1, actually. Infinity tempts us all, whether it be limitless knowledge, everlasting love, boundless wealth, ageless beauty, eternal fame, or whatever else known and unknown that motivates. Life, however, is finite. Between the infinite and the finite, at the point where imagination and reality meet, this is our present boundless struggle. So here, poised at the mystic prism where infinity neither lives nor dies, but refract, is where our story begins.
There you go. And so our story continues. Thank you so much, Ogan. This was so wonderful. I can't wait for our listeners to hear this and connect with you. Happy you could join us today at the TechLink Health Podcast. Thank you.
It's my pleasure. Thank you very much, Justine. Thanks to everybody.
Thanks for listening to this episode. TechLink Health is a healthcare advisory platform for consumers and organizations to stay informed with the latest insights while connecting with healthcare experts for telehealth, e-consults, and consulting services. For more details, visit www.techlink.health.